Thank you, Mr. Chairman. Thanks for the organizers of this very important scientific event. I'm happy to be here to talk about management of subclinical hypothyroidism. This is just a narrative review. So this subject moves around the TSH. As you know, the diagnosis of subclinical hypothyroidism depend on the level of TSH. So this is the outline of my presentation, which includes why the name of subclinical hypothyroidism, why this subject is important, how to manage subclinical hypothyroidism, and we end up with a summary. So regarding the term subclinical, you know, in other diseases, we use subclinical to say that there are no signs and symptoms, while here it means only TSH is high. T4 and T3, free T3 and free T4 are within the normal range. So to avoid this confusion, this is the meaning of subclinical hypothyroidism. Why I have chosen this subject? Because subclinical hypothyroidism is a matter of controversies. There is no agreed statements in different settings, for example, in children, during pregnancy, in elderly, etc. And these are some examples that this is a subject of controversy. The controversy continues regarding the management of subclinical hypothyroidism. Subclinical hypothyroidism in pregnancy, controversies on the diagnosis and treatment. And this is a Nature Review Endocrinology article published 2016. This is the title, Whether Subclinical Hypothyroidism Results in Adverse Health Outcomes Among Children is a matter of debate, and so management of this condition remains challenging. Why subclinical hypothyroidism is important? Because it has been associated with subfertility. And there are a lot of studies about the association between subclinical hypothyroidism and subfertility. I will just show the conclusion of the Danish study, which is, it said that impaired fertility is associated with TSH, anti-TPO antibodies, and mild subclinical hypothyroidism in Danish population of women. So still, it has been said that subclinical hypothyroidism is associated with metabolic syndrome. And you know that metabolic syndrome is the base of all the atherosclerotic cardiovascular disease. So it's associated with increased incidence of subclinical hypothyroidism. This is a cohort study from Nature, published as a scientific report, 2017. Okay, now directly also subclinical hypothyroidism is associated with atherosclerotic cardiovascular disease, including stroke and also ischemic heart disease. So, the Journal of Thyroid Research 2015. This is the title, Cardiovascular Risk Factors in Subclinical Hypothyroidism, a case control study in Nepalese population. And this is the conclusion that subclinical hypothyroidism patients are associated with higher risk for cardiovascular disease than euthyroid subjects. Okay, why it is important? We talked about it. Now we came to the management, how we manage this important subject, subclinical hypothyroidism. As you know, management always includes diagnosis and treatment. Regarding diagnosis of subclinical hypothyroidism, it's almost agreed on it that it is high TSH with normal T3 and T4, and the TSH has been put between 5 to 10 or 4.2 to 10 milli international unit per liter. So this is regarding the diagnosis but how we approach to this condition. When we approach a case of suspected subclinical hypothyroidism, these things are matter. TSH, antithyroid peroxidase antibody, age of the patient, and also fertility and pregnancy issues. We should remember all these three when we treat subclinical hypothyroidism. So, if we see this approach, excuse me, Mr. Chairman, I want to come here. So at the beginning, the TSH, we have 4.2 to 10. Now, we should measure serum autoantibody, anti-TPO. If it is negative, we just do follow-up. And later, I will come what we mean by follow-up. If it is positive, I mean elevated anti-TPO, we look at the age. If the age of the patient is less than 65 or around, we should start treatment. And I will talk what we mean by treatment. Okay, but if the TSH is more than 10, we should start treatment directly. Of course, it should be confirmed at least 2 dependent laboratories. Okay, even if the TSH is more than 10, but the age is more than 65, it needs follow-up. Even if the age is more than 75, even it has been said there is no treatment, is not needed. Now, regarding pregnancy and infertility issues, it has been put as guidelines that the serum TSH level of 2.5 is regarded as a starting point. So if you have a TSH of less or equal to 2.5, just follow up. If it is more, we should start treatment during pregnancy, of course, with some modification, for example, trimester-specific TSH levels, etc. What I mean by follow-up? We mean by follow-up, we wait for 3 months, but if the patient has highly suggestive symptoms, then we should start treatment despite negative anti-TPO. Treatment for 6 months. After 6 months, we recheck the patient. If the symptoms subsided, we continue. If the patient still has symptoms, we should also stop treatment and make the patient for the further follow-up. And we send for anti-TPO at each time of follow-up. So, we start treatment after 6 months, as I said. If there is no response, we stop treatment. If the age is 65 to 75, we do follow-up. If the age is more than 75, no treatment is needed if it is subclinical. I mean, 3T4 is normal. Regarding pregnancy, follow-up should be every month, as it is very important during pregnancy, as Dr. Bayar said, to avoid hypothyroidism during pregnancy. Now, what we mean by treatment? We mean by treatment, of course, levothyroxine. But what is the starting dose? The starting dose of levothyroxine in adults is around 1.6 microgram per kilogram body weight. If the age is 65 to 75, half of that dose should be started. And then during further follow-up, we can increase the dose. We have conditions in which we should start by smaller dose and more cautiously give the treatment, like multiple comorbidities, elderly with frailty syndrome, and also concomitant adrenal insufficiency. You know, in this condition, we should start steroid replacement or cortisol before starting thyroxine therapy. But we have also conditions for early treatment and maybe higher dose. This is during pregnancy, when we have fertility issues, and also in children, of course. In infants, during the first year of life, even around 4 microgram per kilogram body weight is needed. So this was about the treatment. In summary, subclinical hypothyroidism is associated with subfertility. It is associated with metabolic syndrome, also with atherosclerotic cardiovascular disease. And management is individualized according to the setting of the patient's condition. And treatment and diagnosis and follow-up are the main points in its management. And thank you very much.